Hello, my name is Meral Beksaç from Istinye University, Ankara, Turkey. Today I will be presenting you two posters which were presented at the European Hematology Association meeting. And the first one is on belantamab mafodotin, pomalidomide, and dexamethasone demonstrated improved outcomes as second-line therapy versus pomalidomide, bortezomib, and dexamethasone in patients with multiple myeloma. Belantamab mafodotin is the first and only anti-BCMA antibody drug conjugate which has proven its efficacy in the earlier study, which DREAMM-8, which was published in New England Journal of Medicine in 2024, and this led to the approval of this drug in multiple countries. At the primary analysis of drug in DREAMM-8 study, there was a median follow-up of 21.8 months. And in this study, Bela-PD demonstrated, especially in first relapse patients, a significant improvement in PFS compared to the standard of care, pomalidomide, bortezomib, and dexamethasone. In this current analysis today, after additional follow-up, with now a median of 35.8 months, the extension in PFS is more remarkable, and it ranges to 32.6 compared to 12.5 months with a hazard ratio of 0.49. Likewise, the depth of response has also continued its efficacy in favor of belantamab, which is CR rates are higher in the experimental arm, 51% compared to 23%. MRD negativity is 39% versus 7%, and this also extends to a sustained MRD negativity, which is 22% versus 5%. So in conclusion, in this updated analysis, the beneficial effects of the advantage of adding belamaf to the combination of pomalidomide dexamethasone improves both the duration of response, depth of response, and eventually progression-free survival. The second poster I'm going to present again from EHA is, this time it is on sustained MRD negativity in the DREAMM-8 study. Since Bela-PD versus PVD comparison was in favor of the MRD negativity, the kinetics are now analyzed in this poster. The likelihood of achieving MRD negativity is twice more frequent, which is 64% versus 36% in those who are achieving complete remission. Within the ITT population, these rates drop to 27% versus 6% only. Sustained MRD negativity rates were again in favor of belantamab mafodotin combination, which shows 55.8% versus 44.4% among patients who have achieved complete remission. In the ITT population, these rates drop down to 15.5% versus 2.7% only. Those factors which are associated with achieving sustained MRD negativity apart from the experimental arm are patients who have been introduced into the trial after one prior line of therapy, patients who are sensitive to the prior lines of therapy, ISS1, those patients who do not present with extramedullary disease or high-risk features. So, in conclusion, sustained MRD negativity pertained its advantage both in PFS and PFS2. Sustained MRD negativity was maintained up to 4 years in the belamaf combination treatment arm. Thank you for your attention.